So we're looking forward to the second day and pleased to start off with Michelle O'Donoghue. She's from Brigham and Women's, a senior investigator at the TIMI Group, and she's going to speak to us about acute coronary syndrome, updates from the 2025 practice guidelines. Thanks, Michelle.
Good morning, everyone. I'm sure you're all filled up with coffee, which is perfect because there's a lot of content to get through. I had the pleasure of working on the writing committee for the 2025 ACC-AHA guidelines update. And there's a lot of key new content in there to make you aware of for those of you who haven't perhaps done the deep dive and gone through the whole document. So I'll do the best I can to try to distill that all in a way that you can hopefully swallow with your breakfast over the next 40 minutes or so. These are my disclosures. So this is the document that we're really focusing on. So I'll start off with a clinical case, a patient with an ST elevation MI. So a 59-year-old man with a history of diabetes, hypertension, who developed substernal chest pain starting 45 minutes prior to presentation. In the ambulance, his EKG shows inferior ST segment elevations, and he is brought to a non-PCI capable hospital by EMS. So as I go through the STEMI section, here are some key considerations to think about. When to consider fibrinolysis versus transfer for primary PCI. If fibrinolytic is administered, when do we transfer the patient? How to manage non-infarct-related artery disease, as well as just the basics of what anticoagulant is now recommended under the guidelines in this scenario. So as you're broadly aware, we have two basic strategies for reperfusion in ST elevation MI. It's that concept that was put forward decades ago that time is muscle. And so we really race to beat the clock and try to open up that artery as soon as we can to try to prevent further myonecrosis. Primary PCI and fibrinolysis are our two strategies. The reason that we favor PCI is because it has been shown to lead to better outcomes across the board when compared to fibrinolysis. So a reduction in death, reinfarction, less incidence of stroke, as well as reduced intracranial hemorrhage. But there is a tipping point in that equation. The advantage of PCI over lysis attenuates with how long it's going to take to get that patient to PCI, which stands to reason. Where is that tipping point? Well, this is, if the figure's a little hard to orient yourself to, it's the x-axis is looking at the PCI-related delay, and the y-axis is looking at the odds of death with fibrinolysis. And the long story short is around 120 minutes is that tipping point, and I'll come back to that number later as it does factor into the guidelines. So, you have these slides, I imagine in your syllabus or however you're accessing them. I've created them as a build, as I know that they can be a little bit challenging just to stare at in their entirety. But if you have a patient who arrives at a non-PCI capable hospital, the first question, of course, is there a STEMI that is occurring? If not, fibrinolytic should not be administered. Question two, is there a contraindication to fibrinolytic therapy? And if there is, then in that case, you would be transferring the patient. Of course, decisions sort of made for you that you're not going to be administering lytic, but you do want to get that patient to a PCI-capable hospital, and so you would transfer them. The next question to ask yourself, though, is how long has it been since symptom onset? This will be another sort of key concept that I'll walk you through with the STEMI recommendations. If it's been less than 12 hours, that's where we have the most evidence for trying to really quickly open up that artery. So the next question to ask yourself, if it's within 12 hours, is will there be more of a 120-minute delay from the time of first medical contact to primary PCI? So that 120 minutes comes in. Keep in mind, first medical contact, if that patient came in by EMS, the time that that ambulance arrived at that person's house is actually the first medical contact. I think, we've tried to move away from that expression that you're probably more familiar with, door to balloon time, because really it's more from the time of the initial first medical contact to the time that the artery is going to be opened. And that's another misconception where people think, gosh, of course I can get that patient transferred within 120 minutes. But can you get that patient to the next hospital on the table with the artery being opened with 120 minutes is really the question to ask yourself. So if there is going to be longer than a 120-minute delay, that's where you would administer lytic therapy in the absence of a contraindication. But if it's shorter than that, then absolutely ship patients for primary PCI. For those who are longer than 12 hours from symptom onset, it's only that the data are a little bit weaker in that space. By and large, the recommendation is still to ship that patient for primary PCI in that scenario, but the recommendation is a little bit weaker at a class 2A. So the key concepts here, I just put little squares around just to make sure you get the key takeaways. 120 minutes for that transfer time, and then asking yourself the time from symptom onset. So what about if your patient does get lytic therapy? You're at this non-PCI capable hospital, you gave lytic. All of these patients are now going to be shipped to a PCI capable facility because we know that there is a reasonable risk that that artery is going to re-occlude. So if that patient had failed reperfusion, so if they're having ongoing symptoms, the ST segments really haven't come down, there's any hemodynamic or electrical stability, then in that case, you're really going to be getting them as fast as you can over to the PCI capable hospital for immediate rescue PCI. But for the ordinary patient who probably responded to lytic therapy, the goal is to try to get that PCI done now within 2 to 24 hours. So for those patients who do arrive at a PCI-capable hospital, and I promise, don't worry, the whole presentation won't be all in build form, but I think that the key questions to ask yourself here, is there any kind of evidence of heart failure, cardiogenic shock, hemodynamic instability? For those patients, emergency revascularization is recommended irrespective of the time from symptom onset. But otherwise, the time from symptom onset is an important consideration. We talked about that 120-minute window that you have for patients who require a transfer. For those patients who do not require transfer, if they showed up at a PCI-capable hospital, then your time frame is reduced down to 90 minutes. So those are the two numbers to remember there. And then, as we already discussed, if they're 12 to 24 hours out, a weaker recommendation at 2A for a primary PCI approach. And then what if they are longer than 24 hours out? Well, in that case, really we're not exactly sure what to do. If they have evidence of instability of any kind, heart failure, electrical instability, those patients should just go for primary PCI. It's a class 2A recommendation. But otherwise, if they're more than 24 hours out, then the feeling is, for lack of a better term, that the horse has left the barn, that the damage is sort of done. If they're not having ongoing symptoms or anything to sort of push your hand to bring them to the cath lab, that patient does not need to go for primary PCI. So again, those key concepts being the time from symptom onset, and then just try to remember those two, they come up as board questions, 90 minutes or 120 minutes, depending on whether or not transfer is required. Where are we with parenteral anticoagulation? I'm guessing that most of you in this room are most familiar with using unfractionated heparin. These decisions tend to be very institution-specific, but it's important that you know that there is now a class 1 recommendation that for STEMI patients, bivalirudin is an accepted alternative. That is now administered with a post-PCI infusion. So basically, those are your two anticoagulants in the STEMI setting. For non-STEMI patients, though, it hasn't really changed. I'm providing this all for you for information. There are 2B, so sort of the weakest level of endorsement for using bival or IV enoxaparin for patients requiring PCI who are non-ST elevation ACS patients. Fondaparinux should not be given at the time of PCI just because we know that there's a higher rate of catheter thrombosis. So where did the data for bival come from? So bivalirudin has been compared to unfractionated heparin with or without a 2B3A inhibitor across several different trials. By and large, they've all shown favorable effects towards reducing bleeding. But there's always been a lot of debate about whether or not it's as effective for reducing MACE. But we now have a growing body of evidence suggesting that in the STEMI setting, that actually bivalirudin may offer advantages. And these were data from the BRIGHT-4 trial showing not only a reduction in death and bleeding with bivalirudin compared with unfractionated heparin, but also a reduction in death. So that was what led to that Class 1 recommendation. What about complete revascularization? We're very used to treating the culprit artery, but in STEMI patients, we also know that we're going to be treating all the different significant lesions or stenoses that we see on that angiogram. That's because we have now several trials, about 3 trials, that have shown that a strategy of complete revascularization reduces the risk of major adverse cardiovascular events. So we do that over just treating the culprit in isolation. Different definitions have been applied for what is a significant stenosis, but by and large, any stenosis that is felt to be physiologically significant, that is at least 50% in a non-culprit artery. When do you do it? There is a little bit of evidence to support doing it all at one time if you can. That being said, good luck, talking an interventionalist into doing that at 2 in the morning if it's an overnight STEMI patient. But by and large, if that patient does not get complete revasc at the time of their initial primary PCI, they should still be getting revascularized within the next, ideally before hospital discharge or within the first few weeks. The time to not do that is if the patient is in shock, if they're unstable. This has been tested because, it was a little unclear. If you've got a patient who is having perhaps global ischemia, maybe it would help them to revascularize everything. But this was the culprit shock trial, and it showed that not only was it disadvantageous to do complete revasc in that setting in terms of renal complications and other things like that, but also was actually associated with a higher risk of death. So if you have a shock patient, do not do complete revascularization. Before I transition to non-STEMI patients, in terms of cath lab considerations, radial approach is the Class 1 recommendation now to reduce not only bleeding, but it's also been shown to reduce mortality compared to a femoral approach. And there's also now an introduction of using intracoronary imaging for complex lesions in ACS. So obviously, for those of you who are not doing the procedures yourself, this might be less something to focus on, but a lot of your patients may get IVUS or OCT during their procedure. Okay, so I'll transition to a non-STEMI patient, 64-year-old woman with a history of hyperlipidemia who developed chest pressure radiating to left arm with nausea and diaphoresis. EKG shows dynamic ST segment depressions across the lateral leads. First high-sensitivity troponin is modestly above the 99th percentile and rises further on the next draw. Chest pain resolves after administration of nitroglycerin. So key considerations for this case. When do you consider a routine invasive strategy versus a more selective approach? What is the recommended timing for the cath lab? And the age-old question that I usually come here to speak about, which is how do you choose which DAP strategy, which is a talk in and of itself, and duration of DAPT. And also just another key thing for you to be aware of are the new recommendations for lipid-lowering therapy. So this is perhaps a little bit of a complicated diagram, but the concepts are simple. You've got 2 choices, routine invasive or selective invasive. What does selective invasive mean? Doesn't mean sending the patient home, but rather it means further risk stratifying that patient, maybe a stress test to determine whether or not they should go on to the cath lab. Routine invasive just means anybody who comes in with an ACS, bringing that patient to the lab. So the key takeaway here is that an intermediate or high risk non-ST elevation ACS patient should go to the cath lab. And we'll talk about how you sort of make those differentiating features clear. A lower risk non-ST elevation ACS patient, you have a choice. So it's a class 1 to go either way. You can go routine invasive, you can use selective invasive. Either one is reasonable, and there's a little bit of judgment that should be applied as there's less clear-cut overwhelming benefit in that setting. When you look at, these are data across all the different randomized trials of an invasive, or what they were calling back then conservative strategy, the benefit of an invasive strategy is there, but it's not as overwhelming as we sometimes feel like it is, right? So these are older trials, though, in all fairness, and we've had many advances in PCI methods. But by and large, across those earlier trials, an invasive strategy reduced death, MI, or rehospitalization with ACS by about 20%. None of these trials individually showed a mortality benefit. So it's mostly for reduction in reinfarction and rehospitalization with ACS that we pursue this strategy. There are other trials that have looked at the question of timing of when you bring that patient to the cath lab. For a non-ST elevation ACS patient, if the patient came in Friday night, when do you have an argument with the cath lab about trying to get that patient done over the weekend? And we'll talk about that further. But this TIMAX trial is one of the trials that is cited in the guidelines that compared a short delay to the cath lab within 24 hours to a longer one, 36 hours or more. And by and large, the trial did not meet its primary endpoint. So taking the patient to the cath lab sooner, directionally, it looked favorable, but it wasn't statistically significant. That being said, when they looked at subgroups, those patients with a higher GRACE risk score and those patients with higher biomarkers did appear to benefit more from that earlier trip to the cath lab. So hopefully the font's not too small, but I'll highlight the key concepts. This is, I'm just going to walk you through what the recommendations are now for timing of bringing that patient to the cath lab. Unstable, high-risk patient, go right away. There you really want to get that patient to the cath lab as soon as possible. And that includes patients with ongoing refractory angina. Some people liken it to a surgical abdomen. You don't want to just give morphine and, put that patient to sleep. If that patient's really having ongoing angina that's not responsive to nitro, get them to the cath lab. And that's a reason to make that call on the weekend. But also all the typical unstable features that you might look for. For high-risk patients, there's a recommendation, a 2A, so it's a little bit weaker, that the patient go within 24 hours. So if the GRACE risk score is elevated, greater than 140, steeply rising troponin values, this one's a little bit more debated because there aren't strict thresholds that are put in place. But one can imagine that if it was you perhaps as the patient and your troponin value was steeply rising despite being on anticoagulant and you were sort of sitting there on the weekend, you'd probably want to go to the cath lab sooner rather than later. Dynamic EKG changes as well. For your run-of-the-mill intermediate risk patient, there, really you just need to get it done prior to discharge, and there's a 2A for it to be within 72 hours. And as we talked about, for a lower risk patient, so low GRACE risk score, low TIMI risk score, no ongoing symptoms, troponin not elevated, no dynamic EKG changes, you can go either way. And I think it would be very reasonable to really think about a stress test or even something like a coronary CTA rather than directly sending that patient to the cath lab. What about complete revascularization in a non-STEMI patient? This is an important new recommendation in the 2025 ACS guidelines. So the STEMI recommendation I already talked about for doing complete revasc, but now we have evidence that that also appears to be beneficial in a non-STEMI patient as well. These were data from the FIRE trial. This was a patient population all over the age of 75, 65% of whom had non-STEMI as their presenting features. And it showed not only just a reduction in MACE with complete revascularization, but also a reduction in all-cause mortality, 30% reduction in all-cause mortality by doing that complete revasc. And it was very consistent between the STEMI and non-STEMI patients. So this is where the guideline recommendations are. A lot of words here, but the bottom line is that non-STEMI patients also now get complete revascularization, ideally prior to hospital discharge. For indeterminate lesions, physiologic assessment like FFR, that type of strategy can be considered, but it's not a strong recommendation in that regard. But just like with the STEMI patients, cardiogenic shock would be a contraindication to doing that. So I think that I just have that little pop-up there. If you zoned out for a moment, complete revasc in non-STEMI is a new Class 1 recommendation. Okay, so we'll pivot and talk about antiplatelet therapy. I know it's a bit of a whirlwind, so thanks for bearing with me as we go through this. So, many of you might be familiar with the data over the past more than a decade now, suggesting that these more potent P2Y12 inhibitors appear to be beneficial compared to clopidogrel. So these were data from the Triton trial comparing prasugrel to clopidogrel, showed a 20% reduction in major adverse cardiovascular events with prasugrel, albeit there's more bleeding. So we know that it causes more bleeding than with clopidogrel alone, including fatal bleeds, albeit these were infrequent. So who should not get prasugrel? Patients with prior stroke or TIA, there's a contraindication for that. Dose reduction can be considered for patients of older age or low weight, less than 60 kilograms. For Plato, this was the landmark trial for ticagrelor, showing again here was a 16% reduction in major adverse cardiovascular events, but also a reduction in cardiovascular death with ticagrelor compared with clopidogrel. But there's still that increase in bleeding that has been observed. So the recommendations now in the 2025 guidelines is that ticagrelor and prasugrel are both preferred over clopidogrel for a patient who is going for an invasive strategy. When do you administer it? By and large, this is still going to be just administered in the cath lab. There was a lot of debate on the committee about, do you preload, do you not preload? Ultimately, it landed as a 2B recommendation, so a weaker level of recommendation that you could preload if it's going to be more than a 24-hour wait before the patient having to go to the lab. There's some data against preloading with prasugrel, so that strategy could only be pursued with ticagrelor or clopidogrel. To be honest, though, the onset of ticagrelor is so rapid that I don't think it's very compelling to preload with ticagrelor if that's the route that you're going to be going. For a patient who's going to be managed conservatively, ticagrelor has the most evidence. We don't have any real evidence for prasugrel in that setting. Then clopidogrel is sort of your backup plan. If the patient has a contraindication, if you think that they're at too high of a risk of bleeding, clopidogrel is your second option. And as we discussed, prasugrel should not be given for a patient with a prior history of stroke or TIA. So, duration of DAPT. Here there are some important new recommendations as well. So, this has been an ongoing debate for years. And the reason that nobody can really come to a firm conclusion on it has been the fact that most of the trials that have tested the hypothesis of going longer show that when you extend duration of DAPT, it reduces your risk of MACE, but it increases your risk of bleeding. Then it becomes sort of almost a philosophical debate of like, well, which do you care about more? What if these are small MIs versus an overt bleed? Where does that all settle out? And by and large, a mortality benefit has not been demonstrated conclusively for going longer. But these were data from the DAPT trial, albeit now an older trial, but showed a dramatic reduction in stent thrombosis with older generation stents with going longer, as well as a reduction in major adverse cardiovascular events. But, where I think the conversation has been going more recently is why are we always talking about stopping the P2Y12 inhibitor? Why has it always just been assumed that we have to keep aspirin on board? And there has been this feeling traditionally that aspirin, gosh, it must be safer, it's over the counter. But what's interesting is that we have a growing number of studies that have compared just clopidogrel alone to aspirin alone, head to head. And what's really interesting is that clopidogrel has less bleeding than aspirin on its own, and it actually reduces major adverse cardiovascular events more than aspirin alone. So, I think that has been part of why people have been shifting the conversation to not say, when do you stop the clopidogrel, when do you stop the ticagrelor, but rather, when do you stop the aspirin? And that's where the field more recently is moving. There have been several trials that have tested a hypothesis of stopping aspirin compared to just continuing DAPT. And by and large, those trials have tested doing that after 1 to 3 months. No surprise that it reduces bleeding. But what's interesting is it doesn't appear to come at a clear price for increasing the risk of major adverse cardiovascular events. Now, there has been one trial at least that has suggested that clopidogrel monotherapy may not be sufficient post-ACS. And, I don't have time to get into that in detail, but many of you may be familiar that clopidogrel has a lot of response variability. So that might be part of the story, right? If you're going to put a patient on clopidogrel alone, and we know that a third of people don't actually respond to clopidogrel adequately, then, that would make me cringe to just send a higher risk patient out on clopidogrel alone. So there are bleeding risk scores that you can use. The ARC bleeding risk score, which you can see all these different factors that go into that score. If you want an objective way of identifying who's a higher risk patient, who's likely to have a more likely to have a bleeding complication over the next year, as we realize that a lot of people are tailoring DAPT duration based on that. This is what the recommendations now say. The default strategy post-ACS is still a year of DAPT. So that's the default duration. But the important change here is that there's also a Class 1 recommendation for ticagrelor monotherapy. So for a patient who tolerates aspirin and ticagrelor for 1 to 3 months, stop the aspirin. I'm doing that more routinely now in my practice. By and large, we know, of course, it reduces bleeding, and it doesn't have to be just in a high bleeding risk patient. But we know that the ticagrelor on its own is going to be sufficient in all likelihood for preventing that patient's risk of having a recurrent event. Of course, if you have a patient on triple therapy, I'm sure many of you are now doing this in your practice. If not, you should be. But the recommendations are that if the patient needs to be on triple therapy, let's say they develop atrial fibrillation, you're dropping the aspirin definitely in that scenario. And you really should be dropping the aspirin within about a week to a month after ACS. So for that patient who requires triple therapy, the recommendations are for using ideally a DOAC, so one of the newer anticoagulants, in combination with clopidogrel, because there we think that a weaker P2Y12 inhibitor is probably appropriate, and you're ditching the aspirin. The last two parts in orange, I'm not going to get into because I don't want to confuse the picture too much, but there are different strategies that can be used in terms of using genotyping or platelet function testing, the different ways to sort of help guide your decision making. But the key point I just popped up there on the top, and like what do you need to know for a board exam, for instance, is that the default DAPT duration is still 12 months, but there's also a Class 1 recommendation that you can also consider ticagrelor monotherapy after 1 to 3 months. Clopidogrel monotherapy is not your best bet. That's where it's down at a 2B recommendation. So the last part, before I wrap up, is just a lipid-lowering therapy. There are some important new recommendations here. Many of you might be familiar with the Prove It trial, now back in 2003, showing that atorvastatin 80 was superior to pravastatin 40 in terms of reducing the risk of major adverse cardiovascular events. We then had Improve It that took a patient population who had a lower baseline LDL cholesterol and showed that adding ezetimibe on top, albeit the relative risk reduction was relatively more modest, but that's because ezetimibe is a weaker drug. It only reduces your LDL cholesterol on average by about 20%. But how low should we go? This one of our fellows, PK GABA, did this nice analysis with us at TIMI, showing that when you look at outcomes based on where somebody's achieved LDL cholesterol value is, that it doesn't matter how low you go. Look at these at the x-axis. If you go down below 40 milligrams per deciliter, you go down below 20 milligrams per deciliter, that you continue to reduce the risk of major adverse cardiovascular events. Because I know that many of us, just sort of pat ourselves on the back if we see an LDL cholesterol of 60, but in fact, if we push them down further, it does appear to further reduce their risk of MACE. And all of the safety analyses that we've conducted to date show no clear evidence of any adverse effects from going down exceedingly low with people's LDL cholesterol. Well, how early should you be making changes post-ACS? It's interesting. We have a growing number of studies that have looked at the PCSK9 inhibitors early after an ACS. And these were just some studies looking at changes in the plaque morphology and showing that even by week 4, those patients who got started on evolocumab as compared to just a statin alone, that there were improvements in terms of fibrous cap thickness, lipid arc, so that sort of unstable lipid component. All of these things look favorable within a 4-week span after somebody's ACS. So it really, I think, lends further credit to this idea of being very aggressive with lipid-lowering therapy. Tons of words here, but good news, I added in a slide just to distill it down because I didn't want to have your eyes glaze over. What do you need to know? Step 1 for all patients is still maximally tolerated statin. Step 2, though, and this is an important one, is to add a non-statin lipid-lowering therapy as needed to get that patient's LDL cholesterol down below 70 is the class 1, or really below now 55 milligrams per deciliter post-ACS as a class 2A recommendation. And you should be choosing your non-statin lipid-lowering therapy based on how much LDL reduction you need. Post-ACS, gone are the days that you have to use ezetimibe. Now, granted, I'm not the insurer who's having to, I'm not the payer, so you might still run into barriers. But in terms of what the guidelines are saying, look, if you've got a long way to go with needing to reduce somebody's LDL cholesterol, try to get them on a PCSK9 inhibitor. Do that right away. Ezetimibe, bempedoic acid, they both reduce LDL cholesterol by about 20%. The monoclonal antibodies and inclisiran, the PCSK9 drugs, they reduce LDL cholesterol by about 50 to 60%. So that's how you're going to be guiding your decision making. That's what the guidelines say. Of course, the payers are sometimes a different story. But then you recheck a lipid panel in 4 to 8 weeks, intensify as needed. That's the bottom line. So just a couple of last slides just to make you aware, but we're not going to go into this in any depth. But now for patients who show up with an ST elevation MI and cardiogenic shock, there is a recommendation for selected patients to get mechanical circulatory support, specifically with a microaxial flow pump. This is the danger shock trial that showed that there was a mortality benefit from using a microaxial flow pump in these settings. So more of these devices are being used for your unstable ACS patient. And then, of course, cardiac rehab. It's known, and yet people always forget to actually refer their patients for cardiac rehab post-hospitalization. And I have to admit that I actually didn't even know that there are now home-based cardiac rehab programs. So for a patient who says, no way am I going in once a week, I don't have time to do that, there are options for virtual rehab. And so that can be pursued as well. It's a class 2A recommendation. But ideally, of course, having that patient go in person is the best choice. So, top takeaways, last slide. So choose ticagrelor or prasugrel for your patients without contraindication who are ACS plus PCI. The default DAP duration is 12 months, but to reduce bleeding, ticagrelor monotherapy is recommended 1 to 3 months post-PCI for your patients who are on aspirin and ticagrelor. Lower is better. Target an LDL cholesterol less than 55 milligrams per deciliter. High-intensity statin for all are maximally tolerated, but you can add any of the non-statin lipid-lowering drugs and then recheck the lipids 4 to 8 weeks after discharge. If you have a low-risk ACS patient, coronary angiogram is not mandated. You can further risk stratify that patient with stress testing or other imaging first. Treat the non-culprit lesions. Complete revasc in both STEMI and non-STEMI in the absence of shock. Slight preference for one procedure over doing it staged, but that is a little bit more left to discretion. In the cath lab, use a radial approach, intracoronary imaging for complex lesions, and there's this new recommendation, as I mentioned, for the microaxial flow pump in selected patients with STEMI and cardiogenic shock. So I think that might be my last bullet. Oh, secondary prevention and cardiac rehab post-discharge. So with that, I'll wrap it up and take any questions that you may have. Thank you.
Thanks, Michelle, for that tour de force. And we're fortunate, as you as one of the co-chairs of the guidelines, to have you here. If you had to say if there are one or two things that change practice the most from the new guidelines, or probably on your takeaway slides, but from your perspective, what was it?
Yeah, the ones that I'm most excited about are the lower LDL targets. To be honest, almost every other global guideline has been ahead of us on this, and I feel like the Americans have been lagging a little bit. So I'm happy to see the target LDL cholesterol come down. And then I think also this idea of dropping the aspirin is where the field is going. So I'm happy that we're ahead of the curve on that one.
Good. Well, thank you for being ahead of the curve for us. We'll open up for questions on the floor, and then Emily, I know there's a bunch on the virtual. We can hear some of those as well.
Great, thank you. The first question I have is, with the triple therapy, if you're going to stop aspirin in about 1 to 2 weeks, would you check a P2Y12 inhibitor genotype?
Yeah, it's a great question. You know, there's been a lot of interest in genotyping and platelet function testing for patients who are going to be on clopidogrel. I don't feel the need, though, to do that for a patient who is going to also be on a DOAC, because there we know that there are effects. I mean, obviously the DOAC doesn't directly target platelets, but thrombin does. And so by blocking thrombin, you're actually going to have some antiplatelet effect. So we know that the DOACs are going to cause some reduction in MACE, also reduction in stent thrombosis, and even if they're perhaps not a responder to clopidogrel or it's more modest, that's probably still sufficient.
And there's a question about benefit of checking high sensitivity CRP and initiating colchicine in the setting of acute MI.
I didn't get into the colchicine part of the story because just in the interest of time. But it is challenging. We had actually finalized the guidelines before the most recent data on colchicine came out. There had been a couple of trials that had suggested colchicine appears to be beneficial post-ACS. And it had been incorporated into the chronic CAD, the CCD guidelines. We do have a 2B recommendation, which kind of means we're hedging our bets a little bit. So we don't have a strong recommendation for colchicine, but the most recent data suggests no clear benefit. So I have to admit that in my practice, I do not use colchicine. The idea of whether CRP should be used to make that decision-making is interesting, but it hasn't been yet tested.
And how long should patients be on ticagrelor or prasugrel? Are there benefits as compared to clopidogrel after 6 to 12 months?
Yeah, it's a great question because that is one of the things that hasn't been tested in these trials. Is let's say you do a ticagrelor monotherapy strategy. How long are you going to go with that? Are you going to go 12 months and then stop everything? I think people get nervous about that. For a patient who is requiring a DOAC, post 12 months, I think the evidence does now suggest that you can stop all the antiplatelet drugs. But for a patient who otherwise is on a P2Y12 inhibitor monotherapy strategy, after 12 months in a lower risk patient, I will typically downgrade them to clopidogrel or downgrade them to a lower dose of ticagrelor. There's a 60 milligram BID dosing option. That being said, that's not part of the guidelines. That's just my personal practice.
Do you take a more aggressive DAPT approach in patients with ACS and PCI who have elevated lipoprotein A? It seems like this cohort is higher risk for recurrent cardiovascular events. Should we be considering lipoprotein A in addition to DAPT score for duration of DAPT in these patients?
Yeah, well, Lp(a) is another key interest of mine for sure. Basically, it's a great question, but we don't have any evidence to support it per se. We've looked at it within some of our ACS clinical trials. We haven't seen any clear indication that Lp(a) predicts benefit of more potent antiplatelet therapy or more potent lipid-lowering therapy. I'm hedging my bet a little bit because we do know it identifies people at higher risk. The relative risk reduction with these drugs appears to be consistent regardless of Lp(a), but because it identifies higher risk patients, the number needed to treat ends up being smaller, but no clear evidence that Lp(a) should guide your decision making.
And can you clarify for ACS patients who are not receiving aspirin, or why are we, can they not receive aspirin and P2Y12 loading up front before going to the cath lab according to the 2025 guidelines?
They can. So, yeah, to be clear, the timing of initiation of DAPT, the aspirin should be administered as soon as that patient is seen by EMS or in the emergency room. So the aspirin is administered right away, to be clear. The P2Y12 inhibitor, there, it's totally reasonable to wait until that patient is in the cath lab. But if you anticipate that it's going to be longer than 24 hours before that patient goes to the cath lab, and they are going to the cath lab, then clopidogrel or ticagrelor can be administered up front.
And what are the recommendations regarding integralin use in the new guidelines?
Yeah, no, great question. It used to be, gosh, during our fellowship, we used to think about, gosh, when are we starting the 2B3A inhibitor? We had all these charts and stuff. So by and large, 2B3A inhibitors are really now just used for bailout. So that is really just for thrombotic complications in the cath lab. We're not routinely using 2B3A inhibitors, certainly not up front prior to the cath lab, but it's more just as a bailout medicine.
In patients with prior CABG presenting with non-ST elevation ACS, any new updates on strategies for revascularization?
Yeah, I thought the question was actually going to be, I was guessing that it was going to be about antiplatelet therapy, because that is also an area that remains controversial and may continue to evolve, is what is the best choice of antiplatelet therapy post-CABG. Right now, post-CABG, the recommendations are the same as they are post-PCI. That may evolve further in the future. But for all these patients who require, for instance, complete revasc, I didn't go into this in detail, but nobody has really done these trials testing whether that should be done via CABG or whether it should be done via PCI. So for instance, if you have a non-ST elevation ACS patient, they've got multivessel disease, I think a lot of people would probably favor CABG in that setting. That being said, it hasn't been directly tested.
And we have a few questions about aspirin use 12 months post-PCI. First, are you ever just using aspirin 12 months post-PCI as monotherapy? And then are you doing platelet reactive testing if you're going to go with Plavix monotherapy or making the decision between Plavix versus aspirin monotherapy long-term?
I think the reality is that, of course, most of us still have many patients who are just on aspirin monotherapy alone. And, I think an argument can be made if that they're tolerating it well, then they've sort of passed their bleeding stress test. It's not unreasonable to continue them on aspirin. So I haven't been actively switching people who are already sort of tolerating that method. But for patients, like let's say you have a patient who comes in who does have a bleeding event on aspirin, then I think a strong argument can be made to switch them to clopidogrel. Post 12 months, post ACS, most patients are at relatively lower risk where you probably don't need to incorporate platelet function testing at that point. The times that I think about doing platelet function testing or genotyping are really within that first 12 months post ACS, if I'm going to be doing clopidogrel alone for whatever reason, or a patient who is high risk and more than 12 months out.
And can you review again the recommendations for prasugrel monotherapy after ACS, similar to ticagrelor?
Yeah, we don't have the evidence for prasugrel monotherapy yet. Only a couple of trials have actually looked at prasugrel monotherapy but they did it earlier at lower doses. And long story short is that the guidelines only endorse at this point ticagrelor monotherapy. And there is no recommendation at this point for prasugrel monotherapy based on the absence of data. I'll maybe just mention, too, that some of you may be aware that the European guidelines for ACS have a recommendation to preferentially use prasugrel over ticagrelor. The US guidelines don't have that. And that was based on a single trial that suggested that prasugrel was beneficial over ticagrelor, but the American guidelines felt like we just wanted to see more data before saying that that's the preferred strategy.
Then maybe for our last question, we have a couple of questions related to PPI use in the setting of DAPT. Do you do selective or systematic PPIs with DAPT and with triple therapy? And do you recommend switching PPIs for patients who are on clopidogrel and omeprazole?
Mm-hmm. Yeah, great question. I didn't cover it. I probably should have. But PPIs are recommended to reduce risk of bleeding, specifically GI bleeding, of course, for patients who are going to require DAPT, who are at higher risk of bleeding events. Certainly those on triple therapy or who require DOAC, I should say, should be getting a PPI. Although there had been concerns that omeprazole may interact with clopidogrel to inhibit its, sort of slow down its metabolism to its active form, the guidelines are not specific about which PPI to use. There is some thought that omeprazole may be worse in that regard in terms of interacting with clopidogrel, but it hasn't been really shown that there's any clinically relevant interactions, so that's why the guidelines are quiet on that.
Great.
Great, thanks so much.
Yeah, my pleasure.
All right, thanks so much, Michelle.